to introduce Blessed today. Blessed has about another month with us at IU. He completed his postdoc fellowship with working with Sarah and has been a faculty member in the Division of Clinical Pharmacology at IU for the past year or so, and he'll be moving back to India shortly. So he's going to do this one last webinar with us. So he's going to talk a little bit about some of his modeling work with opioids and neonates, if that's correct.
Yes. No. Thanks, Emma. I'm going to talk about opioids in children, not neonates. Can someone tell me that I'm audible? Can someone confirm? Okay, thanks, Amelia. And also, let's start my presentation. Oh. Share screen. This is screened. Do you guys see the right screen?
Yes.
Okay, thank you. So I'll be talking about my work on methadone and oxycodone. It's mainly pop PK, and there's some PD work which I'll talk about too, and the complexities in doing PD work, PD modeling work in such a population. And this is mainly in children undergoing major surgeries. These are actually pretty old children, like there's older children and adolescents. That's the population. Like, yes. So I'll be covering about methadone, and I'll be covering alpha-1 acid glycoprotein. This is a binding protein of methadone. It's a very interesting binding protein, and also oxycodone and this in a similar, actually in the same population. So the first part is about the PK modeling of methadone. A bit on the metabolism of methadone. So methadone is given as a 50-50 RS mixture. So there's it's a racemic mixture where you've got 50% R methadone and 50% S methadone. The interesting part is both R and S methadone, I mean, they have different mechanism of action, and not mechanism of action, but different actions and different routes of metabolism. So they're both metabolized by CYP enzymes. It's just the kind of CYP enzymes which are involved are different. So both have a large component metabolized by CYP2B6 or CYP3A4. CYP2B6 more for S methadone, and the rest of the CYPs which metabolize our methadone are 2D6 and 3, and in case of S methadone, it's 2D6 and 2C18. And it's got this metabolite, REDDP and SEDDP. There's some concern about their clinical activity. We know that they're not, they're pretty inert in terms of pain. But the question is whether they got any QT prolongation activity. We really don't know much about it. And then they get converted to REMTP and SEMTP and multiple minor metabolites, but this is the major pathway. There's a bit of urinary elimination too. So there's a synthetic opioid, and it's got a really long half-life, 24 hours, and it's pretty fast-acting. Contrary to most textbooks would say, actually, it's pretty fast-acting. even faster than morphine. So morphine actually has some delay in starting to act. There's some literature which shows a delay of even 4 hours. So methadone is actually much faster that way. But it's long also. It may stop short. It doesn't act for 24 hours, probably acts for like 12 hours, although the half-life is 24 hours. So maybe it works like for 12 hours. And it's bound to alpha-1 acid glycoprotein, which is an acute phase protein, which means any stress to the body, there is induction in the formation of AAG. There's an inducible component to AAG which gets induced, and there's a high concentration of AAG, and there's the binding of the drug is going to increase, which means there's going to be lesser free drug. And so our methadone is mainly related to the analgesic effect, and it causes all the other classical opioid effects, sedation and the respiratory depression and rest of the things. Methadone has much lesser tolerance compared to morphine. Some of it improves the receptor recycling. So if you know that when morphine binds to the receptor recycling is impaired. While in case of methadone, the recycling is not impaired. There's no receptor desensitization. In fact, if you're giving morphine and methadone together, the recycling is improved, so morphine works better too. So our methadone is like a really good opioid agonist that way. The issue is with S-methadone, which causes QT prolongation. So you may remember methadone as one of the classic drugs which causes QT prolongation, and that's because of this S isomer and enantiomer. And you may wonder why not just give our methadone? Why even give R and S methadone together? You can do a Google search, and if you come with a good answer, please let me know, because I really don't find a good answer for it. They did try in Germany, but for some economic reasons, it was stopped. I really didn't understand what it meant. So the other question which is there with methadone is the metabolite, which is EDDP, whether it causes QT prolongation. So you got evidence for both sides. There's some who say that there's an increase in QTC with EDDP concentration, but we're not really sure, because the methadone concentration and EDDP concentrations are pretty correlated, at least in my study. So it's very difficult to say whether this caused it or the other one caused it. And so there are evidence for both sides of the argument. There's some arguments for some evidence to say that EDDP may cause, and there is some in vitro evidence to show that EDDP does block the HERG channel and may cause QT prolongation. So in this study, it's a novel regimen in the sense that it's not very commonly used. Methadone is not very commonly used in this scenario. And the dose which is given here is also very low. So usually methadone is given as a 24-hourly dose, and it's usually like 0.5 milligram per kilogram. But in this study, it's like 0.05 to 0.1 milligram per kilogram, but given twice Q12-hourly. And the rationale is that you will hit lower peak concentrations, so lower chances of respiratory depression, and the duration of action of methadone is probably not as long as its T-half. There is some evidence to that. So it's better to give it more frequent and not just go by its pharmacokinetic T-half. And this way you can escape with a lower concentration. So these were the research questions we had. What are the patient factors that affect the PK of methadone? Because one of the things we see in practice is that the PK of methadone varies quite a bit between patients. This could be mainly attributed to the CYP polymorphisms because of multiple CYPs involved in the pathway, and And also we know that there are polymorphisms on the opioid receptor part also, which could also affect this pharmacokinetics. Affect the effect of the drug, not the kinetics. So that it could be the pharmacogenes which affect that. The second thing is, the second thing we wanted to know is what's the optimal dose and regimen of racemic methadone, which will provide postoperative analgesia and prevent adverse effects. So what we need is a pharmacokinetic pharmacodynamic model, which has shows a relationship with the analgesic effect, at the same time relationship with the other adverse events. I'll explain how much we could do about this, what were the issues with doing this. So this was a pharmacokinetic data. So the patients were given 0.05 to 0.1 milligram per kilogram body weight of racemic methadone, and intraoperatively it was mainly if you could see the first dose here, all the orange arrows are the doses, the blue arrows are the points at which we sampled concentration. So all the orange lines are the first dose is usually intravenous, and the next doses are oral. And in most patients, in some patients there are more intravenous doses. Some of them did not want to take a oral drug later too, so IV doses. But most patients, they had an IV dose and oral dose. So for the pharmacokinetics here, they'll know that in that case we can actually calculate the true bioavailability. And this is a population like, excuse me. So the median age range was 13 to 15, which means these are pretty kids on the older age range, where you may know that we're not really expecting any maturation effects. And the weight is on the higher side too. The equal number of men and males and females. And these were the surgeries they were undergoing: pectus excavatum repair and spinal fusion surgeries. And these were the genotypes, with the CYP2B6 genotypes based on the population. So there were 3 poor metabolizers and 2 CYP3 star 22, which we classified as rapid metabolizers. So we measured R and S methadone using a chiral assay. So we know the individual concentrations of R and S methadone, and with a reasonably good LOQ and very good CV. And we also measured AAG because we wanted to know what is the effect of AAG on the concentrations or the pharmacodynamic effect. And we performed, we also got exome sequencing done, and we studied for most of the star alleles of these involved CYP and some of the intronic SNPs too. The way we did it is did a literature search, and so what are the other SNPs which are not part of these star alleles, which are reported in literature but not really studied well. So we studied those too. And PK modeling was done with non-MEM with the help of PSN and exposed 4-package and Piranha, and also used R for the plots and other diagnostic things. Used mainly FOSI. We tried SAEM too, but it wasn't required, and FOSI was faster, and so we just stick to FOSI with interaction. And model discrimination was mainly based on the goodness of fit and improvement in OFE. So a reduction in OFE of 3.84 was considered significant between any 2 nested models. And the predictive performance was evaluated using VPCs, 1,000 simulations, and finally the robustness of the final parameter estimates were estimated by bootstrapping, 1,000 bootstraps. So this is a concentration time profile on a log axis. If you may remember, we dose the patients every 12 hours. So if you remember from the previous slide, so this is the dosing every 12 hours, and we are sampling here. So you can see why the dots are more concentrated in this area and over this 12-hour area and the initial area. So that's what you see here. So it's concentrated over here and the initial part. And as most of you may know, this is the beauty of using PopPK. So you've got all this data together. I think I didn't mention this. The yellow dots are the methadone concentrations, and the blue dots are the EDDP concentrations. It does not look very different between R and S methadone, but if you look closely with the individual patient concentrations, you'll notice that S methadone concentrations are slightly higher than R methadone concentrations. It's known that they have lower clearance. And so we got about 400 concentration time points from 61 patients in this study. And yeah, so you can see there's slowly it's accumulating. We have not reached anywhere near steady state. It's the first 2 doses. And this was a concentration time profile of alpha-1 acid glycoprotein. As expected, there was a lot of variability. As it's endogenous substance, the assay is all, the variability from assay is all, there's a certain amount of variability in assay also we expect. Anyway, there was quite a bit of variability in this. But the general trend is increase. About 20 to 30% of patients had no increase in alpha-1 glycoprotein, alpha-1 acid glycoprotein concentrations, and this is seen in literature too. So it's not something which we did not expect. So this was a model structure which we finally. This was the final model structure where we had the dosing compartment where there's an oral dose. So if you remember, the second, third, fourth doses are oral, and the first dose is the IV bolus. So there's a central drug compartment and there's a peripheral compartment, and we also had metabolite concentrations. So we also measured R EDDP and S EDDP concentrations, so that if possible we can do a PKPD modeling with that too. So so we had those concentrations too. So this was like, this is the model structure like, and we know that conversion of the drug to metabolite is what is, what is determined by the CYPs. So this is where we check for the covalent relationship. And the central drug compartment will affect the effect compartment, and maybe the metabolite also may affect the effect compartment. That is something we had to check. So we modeled R and S individually. We did try M3 method for taking care of BLOQs, but we did not have many. We had like just 0.5% of the parent drug was below the level of quantification, and 9.4% of the metabolite concentrations were below the level of quantification. So the M1 method is like you just ignore those concentrations which are BLOQs. In M3 method, you use a Laplacian method to find the likelihood, and that adds information to the model. But in this case, we did not do it. When we tried, it wasn't stable too. And now advanced 6 subroutine, which is a general nonlinear model. And we tried 1, 2, and 3 compartment model. We found that the 2 compartment models were as good as the 3 compartment models. And we estimated bioavailability. As I said, we had the oral dose as well as the IV dose in the same patient. So we could estimate the true bioavailability. And we estimated 1 or 2 Ks. It did improve the model, the way the model ran. It improved the stability of the model, but what we finally saw was that it wasn't really different. The reason being that some of these patients got tablets and some of these patients got suspensions, and we wanted to see whether there's a difference in absorption rate constant. Exponential model was used to describe the between subject variability in PK parameters, and RUV, the residual variability was described by a proportional error model. We tried a combined error model, but this was as good as the combined error model, so we stick to this. And the metabolites were modeled as a separate compartment. We tried doing both simultaneously and sequentially. In sequentially, what we did is fix the estimates of the parent compartment parameters, and then you estimate the metabolite estimates. Sequential is you try to do it together. We couldn't get it to run together, so we had to use a sequential method where we first estimate PK of the parent drug, and then fix it and do the metabolites. We consider the volume of the metabolite as volume of distribution of the metabolite as same as the volume of distribution of the drug, because they are not identifiable. And once that was done, we did allometric weight scaling on all clearances. We used fixed exponents of 0.75 and 1. We did not estimate the exponents. We just used the fixed exponents. And for covariate selection, we did stepwise covariate approach, and with a forward selection and a more stringent backward elimination. At the end of covariate selection, we had AAG on volume of distribution and CYP2B6 as a covariate on CLF. The reasons we tested these were because of the strong biological plausibility. We also tested CYP3A4 genotype, and we also tested CYP3A4 intronic SNPs too. So totally, we tested about 10 of these intronic SNPs. And BMI was found to be a significant covariate for V2 for both R and S method, actually. So one of the things which we wanted to do, but we figured out that our population was not supporting, is this maturation component. So this is not the only way you can add maturation. There's multiple ways to add maturation. This is like one of the classical ways to add maturation. But our age range was so narrow that so if you see, our IQR was like 13 to 15 years. And the weight range is also not much, although we used it as an allometric weight. We used it for allometric weight scaling, but the range was not too much. So we did not find a relationship, and we did not use this. These were the goodness of fit plots. You can see the 4 on the left are methadone, and the 4 on the right are sorry, I'm just trying to find the pointer. Yeah, so the 4 on the left are methadone, and the 4 on the right are EDDP. So you can see that there's a reasonably good prediction, and CWS shows that it's uniformly distributed, so there's not much of model specification. You can see there is a bit of under prediction here and here in the lower concentrations and in the initial part of the concentration time profile. So it was similar for R methadone. You can see that the fit is similarly good. And these are the VPCs. this shows that a model could explain the observed data pretty well. Now, this is an interesting component here, alpha-1 acid glycoprotein. So these are the individual concentrations. So you can see there's a lot happening there. One of the interesting things we noticed is, so if you can see that mostly it's increasing here, but there are patients for whom it's just flat, it just goes straight, it doesn't increase. There are some genotypes of known for alpha-1 acid glycoprotein, but these are like really, really old literature, and you don't find much literature on alpha-1 acid glycoprotein at all, and far less on its genotypes. There are just two SNPs which we know, and these are like defined decades back. And not much is done on this. In fact, if somebody is looking for an area to research, I think this is an amazing area to research alpha-1 acid glycoprotein, because there's so many drugs which are bound to this protein, and we don't know. We know very little about it. So, as I told you before, this is an acute phase protein, which means it increases with stress. In this case, our stress is surgery, post-surgery. This is increasing continuously. This increases for quite a period of time before it starts reducing, at least for 5 days after injury, before it starts reducing. One of the things which we noticed in our study is that the volume of distribution of the drug was not only associated with the concentration of the alpha-1 acid glycoprotein. It was also associated to this ORM1 gene, the SNP on ORM1 gene. And this is colored. Here I've colored it according to the genotype to see that there's actually no correlation between the increase and the genotype. So I think that there is no relation between the genotype and the inducible component or the induction of alpha-1 acid glycoprotein. So we wanted to see whether they were independent before we put both together in the model. So we added one of them to the model first. We added the concentration first, and we saw whether the effect of genotype on volume of distribution is reduced. But we still saw the relationship even after adding concentration on as a covariate. So we added both to the volume of distribution, the central volume of distribution of the drug. So both the concentration of alpha-1 acid glycoprotein and the genotype in this relationship. And these are the other covariate relationship. So you see with CYP2B6, you see relationship with methadone and S-methadone. We considered a linear relationship with CYP. So we have these 4 groups: poor, metabolized, intermediate, normal, and rapid. It's based on the scores we gave. So poor had a score of 0.5, and intermediate 1.1, and 1.5 and 2. So we know that this is not something linear. This is just for the sake of simplicity we used it, because the more number of groups you're going to have, it's going to be difficult to see it's going to see a difficult to find a statistically significant difference. So in this case, we just considered a linear relationship from poor to rapid metabolizers. And also, we used this SNP of intronic SNP of CYP3A4 as a covariate. So this is how the final equation looks like. And this is the relationship you see with this SNP 22467009. This is another SNP which showed a lot of, showed a very good relationship, but we didn't find too many literature references for that. So we did not add this to the final model, but we left this in the final model, this intronic SNP. Yeah. So this was the final parameter estimates like, and this is our methadone. as mentioned here. And if you see the 95% confidence interval of suspension and tablet are actually crossing. So they did not really have a difference there. There may be some difference as expected. Maybe suspensions are absorbed faster, but we didn't really find a significant difference there. And you could see the covariate effects. So these are the covariate effects. So this is looking very small, but it's significant because it's multiplied with the AAG concentrations. And so these are the effects of the covariates we saw. And this is with S-methadone. It's very similar to R-methadone. The structural model and the covariates used for S-methadone are exactly the same. There was not a big difference between these two, R and S-methadone. So we went for the same covariates and for between R and S-methadone. The clearance is slightly lower with S-methadone. This is expected. So the conclusion with the PK modeling study was the model we created adequately described R and S-methadone concentrations and the metabolites in children. And we found that the concentrations of AAG and RS, the SNP on AAG independently predict the volume of distribution of methadone. And polymorphisms of 2B6 and 3A4 show some relationship with the clearance of methadone. Yes.
Great, Blessed.
Yeah.
Oh, I thought you were done there. Okay, sorry.
I'm sorry. So the limitations we saw is lack of concentrations which are not collected during the absorption phase, so we were not able to characterize it fully correctly. And so there were two different formulations of oral of the oral drug, and so that was also difficult to. That also created a high variability in the absorption profile, and the sampling times. We missed a lot of sample in between, so we went back to study after this was published. After this was done and published, we changed the concentration time point to this. It's pretty is more frequent sampling, much better than before. So we expect this is not yet quantified. Once we have this information, I think we'll have a much better model than what we have and we'll be able to do better things with it. So the PD modeling component. So this is a challenge with PD model data. So you got this pain, nausea, vomiting, sedation, and QT prolongation, which you'd like to model. But the collection, there are two issues mainly: the collection of data and how much you can do with these data. So pain is self-reported patient scores. So you see all sort of patients. You see some patients who are like zero. All the pain scores are 0, and there are some patients where all the pain scores are 10. And we really don't know what is causing that. It's maybe the surgery in one person was more traumatic than the other. We don't know. And there are multiple analgesics. I'll show you this in the next plot probably. And there are a lot of sedatives given to the patient. So since it's self-reported and you've got sedatives, it's difficult to trust it. And there's inter-patient variability and there's inter-caregiver variability. There are some caregivers who would happily give a rescue morphine dose if required, and some are not so happy in giving. Yeah, so there's a lot of variability there too. And nausea, vomiting, we did not see many in our data, so we really couldn't use it. And it is like the patient who's prone to vomiting keeps vomiting again and again. So you got like 2 or 3 patients who vomits, and they have got multiple episodes over the next 2 days, and others don't seem to have it. And these patients are all on ondansetron too. Sedation, there's multiple sedations, multiple sedatives, and once again, the sedation scores are not so reliable. And we did not have full pupillometry data. We had just pupillometry data for about 30% of the kids, and yeah. And then QT prolongation. In our case, we had just one QT before the surgery and one after the surgery. So, and these were not time matched, and it's just one occasion. And there are other co-medications also which could have caused QT prolongation, ondansetron being one too. So these are the number of analgesics the patient got. I'm sorry for it's too small for you to read, but you can imagine each one of them. Most of them is an analgesic or sedative. And I just colored it by individual. I don't have to do it, but I didn't have to do it. But it's the color. If you're wondering what's the color is just the individual. So each patient is getting this plethora of medications, and to find the action, to find the action of methadone alone is pretty impossible here. So if you see, this is each of those lines is the vertical line is a dose of methadone or oxycodone or another opioid. So the red lines are methadone, the blue lines are oxycodone, and the green lines are other opioids. And you can see they are so intermingled that you cannot really find the effect of individual effect. And the dots are the pain scores. So this is the x-axis is the model predicted concentration at that time point, because we had more time points at which we had pain scores and we did not have concentrations measured. So this is model predicted concentration versus pain score. So if you see the concentration versus pain score, you really don't see anything there. And if you look at pupil diameter versus pain score, once again, not a great relationship. And difference between post-op QTC and pre-op QTC, once again, not a great relationship. We looked at multiple things. We looked at ratios. We weighted it to the baseline, nothing. We didn't find any relationship here too. But we did see this relationship with it's a trend more than a relationship. So you see this trend with FAH, that is fatty acidamide hydrolase, and OPRM is the gene for opioid receptor, and you see some trend over with that PD type. And this is with pain score versus the closest concentration. So there's no predicted concentration here. The closest concentration is this pain score. Once again, you don't see any relationship. The line is going down because you just have these zeros here, even at highest concentration. So if there was a effect, I would have seen with the highest concentration, it should come down, but with you shouldn't see these ones over here. So you really don't see a effect there. And so we tried normalizing the pain score to the average. We tried normalizing the pain score to the average pain score in that patient, or the maximum pain score in the patient, because we hypothesized maybe some people have a different tolerance, a threshold to pain, and we tried normalizing it, and it did not really work. And this is median pain score versus all the opioids morphine equivalent dose. So one of the cool things you can do with opioids is that you can convert it to, or any opioid, you can convert it to a morphine equivalent dose. So even if you give 5 types of opioids, you can put it together as a morphine equivalent dose. Each one has got its score. So use the score, put the weights together, put the doses together, and you can make one morphine equivalent dose. So the median pain score, you see that there's no relationship with all the morphine equivalent dose. There seemed to be some trend in all of these. You can see that median pain score is related to morphine, the amount of rescue opioids used. So more the pain, the more amount of rescue opioids used. Makes sense. Maybe there is some trend there. One thing which encouraged us to go ahead and try a PD model was this. One of the things we noticed is with the increase in a model predicted concentration, the number of rescue doses required in a patient was reducing. So that was looking as if there's some effect of the concentration to a number of rescue doses required. So now the way to go ahead was to do a repeated time to event model. Time to event being the rescue dose, the patient taking the rescue dose. So we tried this Weibull or Gompertz or exponential distribution model to do this repeated time to event analysis. So it's a PK/PD analysis with the PD component being analyzed in a time to event way. So with a hazard analysis. So the issue in doing an analysis like this is you cannot see a DB versus IPRIT or observed as this predicted plot. The only way you know whether your analysis really works is to actually do a VPC and see whether the VPC fits the data you got. And you have to go time to first dose, time to second dose, time to third dose, time to fourth dose. So you can check each one of those. And this is the best model we got. And you can see that we are absolutely not predicting the time to event. So we think it's because of the amount of noise in the data. The data is so noisy that you really cannot predict, and it would have been a miracle if you could have predicted it. Okay, this is an interesting component, AAG. So there's diurnal variation in AAG, which we know from literature. AAG is the alpha-1 acid glycoprotein, which is the binding protein for methadone. So you can see that the serum concentration of AAG sort of reduces towards at the night, and then once again it increases. And also there are enough literature to show relationship between percentage of free R methadone versus AAG concentrations. So there is enough literature to show a relationship between AAG and percentage free methadone. So this is something we expected to see in our data. We expected that we'll find a relationship between free fraction and AAG. So we went ahead and even did a free drug concentration of both R and S methadone. So this is individual concentration of AAG. So you can see that most people, there is an increase. There's quite a bit of intra-patient variability. It could be due to a lot of reasons. One of the things could be SA2, but reasonably okay. It's reasonably okay. You see a trend in most people. Most people it's increasing. Some people it's flat, and rarely it is coming down. This is the relationship between percentage unbound of R and S methadone. So there's no relationship. This is between R and S methadone. So percentage unbound between R and S methadone, there's a relationship. But if you this is AAG versus clock time, just to show you the increase once again. But if you look at AAG concentration versus fraction unbound R methadone or S methadone or the racemic methadone, there was absolutely no relationship. So this was something we did not expect because there's so much literature, all in the old times, but I mean by old times, 70s and 80s, so not really old, but not any time in the recent past. But here we really don't see any relationship. I have colored it by time. Once again, I don't see a relationship with time to here. So we really don't know what's happening here. We have few things we suspect. One of the things is that AAG is known to undergo a lot of glycosylation, and it can get glycosylated to different lengths. So maybe there's some evidence to show that actually glycosylation affects binding. So we're thinking maybe there is something to do with that. And also there's evidence to show that the inflammatory markers can enhance binding affinity with alpha-1 acid glycoprotein. So either this or that, and also we know that AAG has got different AAG by itself, not just the glycosylated AAG. There is the inducible form of AAG and there's a constitutive AAG. Maybe there's difference in binding there too. And the pH in the post-operative period, we don't know how much affects in case of AAG. So there are a lot of studies in albumin, but there's not much of studies done AAG. So this is something which we still don't know, which is a great area for research. So I'm going to just touch upon oxycodone modeling because it's not very different from, it's the same population. So oxycodone mainly it's got all these metabolites, but one we are looking at is noroxycodone, oxymorphone, noroxymorphone. The reason being noroxycodone is the most common one. Oxymorphone is not so, it's just 11%. There's a reasonable amount of noroxymorphone. So this is the orange lines are the doses and the blue lines are the samples. So we got samples at these points and later at these points. A similar population, slightly smaller population. And similar research questions. What are the factors which affects PK of oxycodone, and what are the ones which, how do we optimize the regimen? And you can see that this is the model like. So it has two metabolites, then both the metabolites can form another noroxymorphone. Now, noroxycodone is not active, or it's much less active. It's like 1/10 active as oxycodone, but it's a major metabolite. And I may not be right on that. It may be 1/40th active, noroxycodone. And oxymorphone is more active than oxycodone, 4 times more active than oxycodone. And noroxymorphone is also more active than oxycodone. So the metabolites definitely matter here. And 3A4 and CYP2D6 are the enzymes in different combinations which metabolize this. And one of the issues we had with this was a lot of BLOQs below the level of quantification. And this is something we should have dealt with before the study was started, but we did not expect such low concentrations. And that was a big issue finally, especially with the oxymorphone. We couldn't get a good relationship with the covariates at that point because the concentrations of oxymorphone is very low. These are the observed and the predicted. So if you just look at the right top, it's the individual observed as the individual predicted. And this is for oxymorphone and noroxymorphone, which is okay, but you can see oxymorphone is like the population predicted is really, really bad. So these were the VPCs, and this is some of the relationship we noticed in this population, mainly for noroxymorphone, not for oxymorphone, because the same issue. The concentrations there's so many concentrations below the LOQ. So here we use CYP2D6 activity score. The good thing about CYP2D6 is there's like somebody has already defined these activity scores. So you're not imagining an activity score. So it's just easy to just take it and use it. So there seemed to be a trend. We did use that in the model. And also with formation clearance of noroxycodone, we use CYP3A4 as CYP3A4 genotype as a covariate. I'm going to skip this. This is just without the model. Even without the model, we did see some trend. There's not too much to speak here because you can see that it's not really looking significant, but you see there's a trend with CYP2D6 genotype with oxycodone, the length of stay and average morphine equivalent dose per kg. And I'd like to acknowledge all these people, especially Sarah and Brian, who sits with me every week to discuss, and Mike, without whom I couldn't have done any of this work, for being very patient with me with all my stupid questions, and all these people in clinical pharm, and my PI till last year, Dr. Sindel from anesthesia, was very supportive and was willing to spend all those money on EAG and free methadone levels, which finally did not really help. And all this funding, MPRINT and the other ones from Dr. Sindel. Thank you. I can take any questions, if any. I'm not sure whether I can hear them.
Yeah, I think you can put the questions in the chat if you have any questions.
Okay. I don't know where to see the chat. Okay, I found it. I hope I didn't put people to sleep.
Can you see the questions there, Blessed? So
I don't see a question. Do you
yeah,
see?
so it's in
Oh.
the Q&A, but I can read it here. Are there PK values in children much different from adults after surgery? So are the PK values in the children much different from those in adults after the surgery?
No, not really. Thanks for the question, Dr. Prince. Not very different from adults, especially I think it's because this population is adolescent population. So not very different from others, yeah, from adults. Oh, and thanks for the question, Dr. Bob. So, I don't know in case of oxycodone whether the effect duration is shorter than the PK half-life. It is true with methadone that the effect is shorter than the PK half-life. It could be because of it could be the reason I think is that methadone, although it has that really long half-life, it reaches that concentration, really low concentrations soon after the distribution phase. So I think that is the reason rather than acute tolerance development. In fact, it is known to have much lesser tolerance development compared to the rest of the opioids. That is one of the reasons I think we should use methadone, and could be the main. And also, one of the things they're actually studying in this study is long-term relationship to see whether there is any chronic pain. One of the other things we know is with this surgeries that there can be chronic pain in the long term. So and people who don't develop these acute tolerances also seem to not have this chronic pain. So methadone seemed to be good in a lot of ways. I see a hand up for sure.
Yeah, good afternoon. Sorry, I'm not able to type in the chat.
No problem.
So I guess my question was with regards to the variability in alpha-1 acid glycoprotein.
Yes.
The age range that was being studied in this study was very narrow.
Yes.
Yet the variability was very large. So it raises a few questions in my mind.
Yeah.
Was there a baseline alpha-1 acid glycoprotein level before methadone was administered?
Yes.
That's number one. And
yes.
Number two, were there any co-administered drugs that might be bound to alpha-1 acid glycoprotein, which were different amongst the different patients? And maybe that could be a reason for the variability seen in alpha-1 acid glycoprotein, because if the protein is bound to the drug, then you're not going to be able to measure the protein.
Yes.
Which I'm assuming that you are just measuring the protein and not when it's bound to something.
Yes.
So just curiosity questions. Thank you.
Yeah. So the first question: did we have a baseline? This first sample was taken during surgery, so this was right before methadone was given. So we did have a sample before methadone was given, but this is through the surgery, not before surgery sample. So we really don't know whether this is the baseline. We did try using the baseline in our models. Didn't really help. The second question is about other drugs which binds to alpha-1 glycoprotein. I did check this. I can't remember that there was anything on the list which binds to alpha-1 glycoprotein. The other, even if there is one, I'm not sure whether there is saturation of the binding sites that reduces the binding to alpha-1 to methadone. Saying that, I'm not. That is true with albumin. We know that albumin has so many binding sites and easily does not get saturated. But I'm not sure how true it is with alpha-1 acid glycoprotein. As I said, it's not studied so well. Maybe that is something we should, along with the other questions we have about alpha-1 acid glycoprotein, maybe that's something we need to look up also, how easily it gets saturated. Thank you. Next questions. There are no more questions. Do you think we need to an end?
Yeah, I think so. I think it was a great presentation and it stimulated a lot of good discussion. So I think if anybody has any questions, they can probably follow up with you by
Yes.
email.
Yes.
So, yeah, thanks
Thank
so
you.
much for presenting and thanks for everybody for attending today.
Thank you.